Medtronic technologies impacted more than 72 million people in the last year, equating to 2 people every second. Harnessing the power of technology to take healthcare further, each technology has unique benefits designed to serve patients. The goal of this program is to get closer to the patient and delve into the challenges and impact of each technology in practice. This is the Medtronic MedEd Learning Experience. The Invos monitoring system should not be used as the sole basis for diagnosis or therapy and is intended only as an adjunct in patient assessment. The contents and conclusions of the following programs are solely those of the speakers unless otherwise cited. The speakers are responsible for all content and any necessary permissions. The speakers receive funding from Covidian LP, a Medtronic company, for this speaking engagement. Medtronic's medical education programs are offered to provide attendees education on FDA-cleared indications and use of our products when applicable. For this segment of the series, a discussion on the utility of Invos system, how can NIRS be interpreted? To help answer this question is Dr. Ronald Bronicki, Professor of Pediatrics at Baylor College of Medicine, Section of Critical Care Medicine and Cardiology at Texas Children's Hospital.
The NIRS-derived oxygen saturation functions as a surrogate for the corresponding venous oxygen saturation. Applying fixed principle and the principles of venous oximetry is necessary to interpret NIRS oximetry. Manipulation and simplification of fixed principle brings us to the following equation and the oxygen extraction ratio, where the NIRS oxygen saturation is used in place of the SvO2. As Fick's equation illustrates, the oxygen extraction ratio evaluates oxygen demand in relation to oxygen delivery for that tissue being evaluated. For this reason, the oxygen extraction ratio is not an indicator of cardiac function, cardiac output, or oxygen delivery. And as we mentioned previously, NIRS oximetry enables us to assess the relationship between VO2 and DO2 on a global as well as regional level. When the determinants of VO2 and or DO2 are altered, there are systemic neurohormonal responses that attempt to maintain a normal VO2-DO2 relationship. With alterations in oxygen consumption, for example, with labored breathing, cardiac output and oxygen delivery increase, and the relationship between VO2 and DO2, and thus the oxygen extraction ratio, are largely maintained. If the increase in oxygen demand is too great, and or the compensatory circulatory response is inadequate, the oxygen extraction ratio increases. With a decrease in oxygenation and or a decrease in oxygen carrying capacity, the resulting decrease in oxygen content stimulates an increase in cardiac output and oxygen delivery, and the oxygen extraction ratio are largely maintained. And as before, if the decrease in oxygen content is too severe, and or the compensatory circulatory response is inadequate, the oxygen extraction ratio increases. When cardiac output and thus oxygen delivery are limited, the only acute compensatory mechanism remaining to maintain tissue oxygenation is an increase in the extraction of oxygen from blood. On a regional level, each viscera, to varying degrees, attempts to maintain a normal VO2-DO2 relationship, which establishes baseline normal oxygen extraction ratios. These regional visceral mechanisms also respond to the systemic neurohormonal influences, which may be at odds with regional tissue demands. These processes are known as metabolic and pressure autoregulation. This figure depicts the process of pressure autoregulation, in this case for the brain, but similar relationships exist for other viscera. This figure illustrates that within a wide range of arterial perfusion pressure, flow remains independent of pressure. A decrease in pressure sensed within the viscera stimulates vasodilation to maintain flow and thus oxygen delivery and a normal oxygen extraction ratio. At a certain pressure, represented by the lower inflection point, LIP, maximum vasodilation has occurred. Vasodilatory reserve is exhausted, and flow becomes pressure passive. As pressure falls further, so too does blood flow and oxygen delivery, and the oxygen extraction ratio begins to rise. This figure relates changes in the relationship between pressure and flow as oxygen demand and or oxygen content are altered. As oxygen demand increases and or oxygen content decreases, resting blood flow increases. Evaluate curve C2 relative to curve C1. C2 has shifted upward. When this occurs, vasodilatory reserve has decreased. Evaluate R1 relative to R2. R3 represents the change in these relationships if the pressure head, arterial blood pressure, is increased. Metabolic autoregulation matches flow and oxygen delivery to oxygen demand, as the determinants of oxygen consumption and oxygen delivery are altered, producing a normal oxygen extraction ratio. Mediators include, for example, tissue levels of adenosine and oxygen. As with pressure autoregulation, this process is mediated through alterations in vasomotor tone. The figure in the top to the left illustrates that as oxygen tension is altered, in this case the jugular saturation, the SpO2 remains constant until the PO2 falls below 65 millimeters of mercury or so, at which point the arterial saturation begins to fall below 100%. As this occurs, the jugular saturation falls, but so long as the decrease in content is not too severe and or the circulatory response is adequate, the oxygen extraction ratio remains normal. Similarly, with changes in the hemoglobin level, the jugular saturation and thus oxygen extraction ratio remain normal due to a corresponding change in vascular resistance. If, for example, the hemoglobin falls, so long as the decrease in content is not too severe and or the circulatory response is adequate, the oxygen extraction ratio remains normal. And last, with changes in metabolism, as with perturbations in oxygen content, the jugular venous saturation and the oxygen extraction ratio remain normal due to corresponding changes in vascular resistance. At this point, I think a word or two on the ability of tissues to increase the extraction of oxygen is indicated. When oxygen demand exceeds oxygen delivery, the oxygen extraction ratio increases. The ability of tissues to extract more oxygen from blood results primarily from vascular recruitment. For example, when stimulated by tissue hypoxia, capillary density increases, which increases the surface area for gas exchange. The cross-sectional area of gas exchange vessels increases as well, which decreases red blood cell velocity, increasing the red blood cell transit time and time for diffusion. This figure nicely summarizes many of these principles. As we discussed, autoregulatory mechanisms attempt to maintain a normal oxygen extraction ratio as the determinants of VO2 and DO2 are altered. The critical DO2 and critical oxygen extraction ratio are defined by the onset of a decrease in oxygen consumption as oxygen delivery is decreased without a change in oxygen demand. This is an important and perhaps confusing concept. Oxygen consumption and oxygen demand are not synonymous. That is to say, they are not necessarily equal. For a given oxygen demand, a decrease in oxygen delivery determines the onset of tissue hypoxia or shock by demonstrating a decrease in oxygen consumption, with the emphasis on no change in oxygen demand. When this occurs, oxygen demand is greater than oxygen consumption. This defines the critical oxygen delivery value. The corresponding oxygen extraction ratio is the critical oxygen extraction ratio. The critical oxygen delivery changes in parallel with oxygen demand. However, the critical oxygen extraction ratio remains constant in the range of 60 to 70% because it evaluates oxygen demand relative to oxygen delivery. Importantly, lactate levels in blood or tissue do not begin to rise or accumulate until lactate production begins to exceed its clearance, a process which begins once the critical oxygen extraction ratio has been exceeded. These are the normal and abnormal venous oximetry values, which serve as a reference for interpreting NIRS oximetry readings. A normal mixed or central venous oxygen extraction ratio is 25 to 30% or so. And when the relationship between oxygen consumption and oxygen delivery is disturbed, an oxygen extraction ratio of 30 to 50% is consistent with a limited cardiac output and oxygen delivery. An extraction ratio of 50 to 60% is consistent with impending shock. And an oxygen extraction ratio that is rising above 60% is consistent with the onset of shock. On a regional level, the normal oxygen extraction ratio for the brain is 35% or so, 15% or so for the kidneys, and 30% for the mesentery. And the corresponding critical oxygen extraction ratio for the brain is a value of 60%. For the kidneys, it is unclear, and for the mesentery, it is 60%. In summary, we are determining the oxygen extraction ratio and evaluating oxygen delivery relative to oxygen consumption. Consider the determinants of oxygen consumption, oxygen delivery, and the processes that may affect them on a regional and global level. And finally, consider the range of oxygen extraction ratios, normal to impending to critical.
Please tune in next week for a new segment from this series wherever you find your podcast. This is the Medtronic MedEd Learning Experience. Thank you for listening.